Let us travel in a journey into different modalities in macular hole surgery. The first traditional technique is dyeing vitrectomy with total internal limiting membrane peeling, starting with core vitrectomy, then staining of the vitreous with triamcinolone, then induction of BVD just temporal to the disc, then completion of BVD. After this, we stain the ILM with BBG, trying to elevate a flap using a tin scraper, then catching the flap with a forceps, removing as much as possible of the ILM over the macula. This technique was successful in a very good percent of cases in closure of macular hole, especially in small ones less than 400 micron. The second technique is inverted flap technique. In this case, I used perfluorocarbon liquid Decaline. The value of Decaline is to assist the ILM to be sticky to the macular hole, lessening the risk of losing the inverted flap. Doing ILM peeling, leaving a rim at the edge of the macular hole to cover the macular hole, then augmenting ILM flaps with multiple flaps. So if one is lost, the other flaps are working good. Then doing air fluid exchange, aspirating the fluid at first, and after aspiration of the fluid, then going to aspirate the Decaline. Aspirating the Decaline is better to be performed on the nasal side, not to disturb the ILM flaps. Then leaving the eye on just air. Another technique is temporal flap technique. As we see, this patient has a traumatic macular hole and choroidal rupture just temporal to the disc, starting to make a slide of ILM at the temporal side. This slide is the base for creation of a larger flap to cover the macula. The temporal part of the retina, the temporal part of the macula is the thinnest part of the macula, especially in high myopes, so we have to be cautious. Then the flap is covering the surface of the macular hole. Another technique is retinal graft. This patient had a recurrent macular hole RD with previously built ILM, so I decided to make and fashion a retinal graft. After injection of a bubble of perfluorocarbon liquid, and with the help of chandelier light, using the forceps in one hand and the scissor in the other hand, then fashioning and cutting the retinal graft, and then increase of injection of perfluorocarbon liquid, and sliding the retinal graft over the surface of the retina to cover the macular hole. Now the retinal graft is covering the macular hole well. Another technique is doing amniotic membrane graft. This patient was previously operated and the retinal graft was done, but unfortunately the retinal graft was displaced, partially covering the macular hole. This was a very large macular hole, about 2 disc diameters. Part of the graft is covering and part is outside, so I decided to do amniotic membrane grafting. Putting the amniotic membrane on the surface of this very large macular hole, then unfolding the amniotic membrane under perfluorocarbon. The amniotic membrane can be used with stacking the amniotic membrane inside the macular hole, and this helps to release a growth factors, or just covering the surface of the macular hole. So the prognostic criteria in macular hole surgery are the following: a stage of macular hole, early stage of macular hole response well anatomically and functionally, duration of symptoms if less than 6 months it is good, preoperative visual acuity, size of macular hole IS, os junction, and DA limb continue to add the edge of the macular hole and OCT indices. These are multiple OCT indices. One of them is macular hole index, which is the division of the vertical diameter over the largest basal diameter, and if it is equaling or less than 0.5, so it is good prediction for a good visual acuity postoperatively. And thank you.